Hello, my name is Jeff Borer. I'm going to be speaking about the pathophysiology of heart failure as it's now being understood in an evolving milieu. The objectives of this program include an overall learning objective to construct a set of appropriate pharmacological regimens based on an understanding of the pathophysiologic mechanisms of heart failure. The module learning objectives are that after completing this activity, the learner will be able to list key differences between heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction, describe the pathophysiological mechanisms of heart failure that result from neurohormonal activation, and list the types of medications, the groups of medications that act on key targets in the pathophysiology of heart failure. Heart failure is a syndrome. Pathophysiologically, it involves the inability to provide adequate cardiac output to support normal bodily functions at rest or with exertion, or to provide this output only when cardiac filling pressures are abnormal. Clinically, heart failure is a syndrome characterized by breathlessness, fatigue, and edema caused by an abnormality of the heart. Heart failure can be divided primarily into two groups. First, heart failure with reduced ejection fraction. I'll define that further in a minute. And second, heart failure with preserved ejection fraction. We know a good deal more about the reduced ejection fraction group than the preserved ejection fraction group, but we're gaining on the preserved ejection fraction as well. HFrEF, or heart failure with reduced ejection fraction, is also referred to as systolic heart failure. Randomized controlled trials have mainly enrolled patients with HFrEF, at least in recent years. To date, only in these patients have effective therapies for symptom relief and natural history improvement been demonstrated. HFpEF, which is also referred to as diastolic heart failure, involves several different criteria for its diagnosis. Diagnosis of HFpEF is challenging because it largely involves excluding other potential causes of heart failure, particularly non-cardiac causes of symptoms that mimic those of heart failure. To date, though therapy for symptom relief is possible in people with HFpEF, no effective therapies have been demonstrated conclusively to improve natural history in patients with this entity. In recent years, it's become clear that there's a sort of a midway group, an in-between group, called HFpEF borderline, which includes patients whose ejection fraction exceeds the 40% limit for HFpEF and is lower than the 50% lower limit for HFpEF. These patients with ejection fractions 41 to 49 fall into a borderline intermediate group. Their characteristics, their treatment patterns, and their outcomes seem to be more similar to those of patients with HFpEF than of HFrEF. HFpEF improved is another category that's being increasingly recognized. It seems that some patients with HFrEF can improve and develop HFpEF. Patients with improvement or recovery in EF may be clinically distinct from those with persistently preserved or reduced ejection fraction, and we need more research to better understand and characterize these patients. HFrEF accounts for up to half of the patients with heart failure. This has been shown in registries like the Optimize-HF registry and the Medicare registry. However, it's important to remember that signs and symptoms of heart failure are very similar in patients with HFpEF and with HFrEF. They all manifest peripheral edema, orthopnea, paroxysmal nocturnal dyspnea, dyspnea at rest, rales in the chest on physical examination, unusually elevated neck veins, and they also have third heart sounds and cardiomegaly. So clinically, these syndromes are very similar. Outcomes are similar. Treatments are different. The pathophysiology of heart failure needs to be understood, or is best understood largely in the setting of HFrEF. We really don't understand nearly so well the pathophysiology of HFpEF. In HFrEF, however, there seems to be generally an initiating myocardial injury that causes left ventricular systolic dysfunction. This may lead to a perceived reduction in circulating volume and pressure by body sensors, even though the circulating volume and pressures may be increased. The result of this misperception is activation of a variety of hormonal systems. The sympathetic nervous system, the renin-angiotensin-aldosterone system, endothelin, arginine, vasopressin, etc., and eventually leads, if there is volume overload, to natriuretic peptide release by the heart. The result of all these hormonal activations is systemic vasoconstriction and renal sodium and water retention, which potentiates the myocardial dysfunction, the systolic dysfunction, and the entire cycle begins again. Neurohormonal activation is a hallmark of heart failure. If one compares the blood values, the blood levels of certain hormones in patients without heart failure versus those with heart failure, there's a clear difference. For example, plasma norepinephrine is significantly greater in patients with heart failure than in normal subjects. Plasma renin activity is significantly greater in patients with heart failure than in normal subjects. Arginine vasopressin levels are higher in patients with heart failure. Atrial natriuretic peptide levels are markedly higher in patients with heart failure than in normals. Key therapeutic targets in heart failure can be understood from the pathophysiology. In order for the renin-angiotensin-aldosterone system to be activated and active, angiotensinogen, a precursor that is manufactured in the liver, has to be converted to angiotensin 1, which happens with catalysis by renin from the kidneys. When angiotensin 1 is formed, it in turn needs to be catalyzed to convert to angiotensin 2, which is achieved with the mediation of angiotensin-converting enzymes. Also, chymase provides another pathway by which angiotensin 2 can be produced from angiotensin 1. Ultimately, angiotensin 2 combines with the angiotensin receptors at effector sites, leading to some of the problems that we see in patients with heart failure. In this system, the renin-angiotensin portion of the renin-angiotensin-aldosterone system, we can intervene now at several sites. We have direct renin inhibitors. We have angiotensin-converting enzyme inhibitors. We have angiotensin receptor blockers. All of them can impact on the activation and activity of the renin-angiotensin system. Once angiotensin 2 is formed, it in turn stimulates the adrenal glands to release aldosterone. Aldosterone acts on the kidneys, specifically to cause sodium and water retention, which is part of the vicious cycle of heart failure. We now have mineralocorticoid receptor antagonists that can block the aldosterone, drugs like spironolactone. So we have many places at which we can impact on the renin-angiotensin-aldosterone system, potentially benefiting patients with heart failure. It's important to note, though, that the kidney, which produces the renin, which catalyzes the conversion of angiotensinogen to angiotensin 1, can be affected by beta blockers as well. Beta blockers can directly block the manufacture of renin by the kidney. And in fact, years ago, it was demonstrated that certain beta blockers, when given to patients with high renin hypertension could be very effective in lowering the blood pressure. They're also very effective in patients with heart failure, but probably for a different reason that we'll talk about in a few minutes. Now, I've told you the loci at which interventions might be useful in patients with heart failure. Let's look at the results of trials. Outcome trials have been conducted in patients with HFpEF and in HFrEF. First, let's talk about HFpEF. The first trial that clearly separated people with HFpEF from those with HFrEF was the CHARM trial. The CHARM group of trials included a subset of about 700 patients called CHARM Preserved, in which patients were treated with candesartan or placebo on top of some other heart failure therapies. The result was virtually no impact of candesartan, which is an angiotensin receptor blocker. Though the results were suggestive, the putative improvement with candesartan didn't reach statistical significance. Well, of course, there may be differences among different angiotensin receptor blockers, but given the suggestive results with candesartan, another trial called I-PRESERVE was performed studying irbesartan, a long-acting angiotensin receptor blocker, versus placebo. In I-PRESERVE, the results were even more clear that the angiotensin receptor blocker really had no impact at all on outcomes in patients with HFpEF. Angiotensin converting enzyme inhibitors have been used as well. In one, the ACE inhibitor perindopril was compared with placebo, and once again, there was absolutely no effect on outcomes in heart failure. And finally, the TOPCAT study was performed. TOPCAT used spironolactone versus placebo in a group of patients with HFpEF. Here, the results were complicated by the possibility that some patients weren't included in the drug-receiving group the way they should have been. But when the results of the trial, as they were submitted to the coordinating committee, were analyzed, there was no effect of spironolactone on top of versus placebo. However, there's enough of a question here so that more trials undoubtedly will be undertaken. Now, how about HFrEF? We have a lot of evidence for benefit here with a variety of agents. First, ACE inhibitors, angiotensin converting enzyme inhibitors. The first large trial to show that ACE inhibitors improved outcome in patients with HFrEF was the consensus study. That was reported out in the 1980s, actually, and showed a rather dramatic difference in outcomes in patients who received enalapril versus those who received placebo. These were very sick patients. They were New York Heart Association functional class 4. A little bit later, the solved treatment trial was performed and reported. That included patients with less severe heart failure, functional class 2 and 3. And here, even though the patients were less severe, and even though the benefit of enalapril was less marked than in consensus, there was a clear and statistically significant improvement in outcome in patients who had HFrEF. Angiotensin receptor blockers have been studied as well. Several trials have been performed, and they've generally been positive in that use of an angiotensin receptor blocker, or ARB, has been beneficial versus placebo for patients with heart failure. However, a question that obviously would arise in that situation would be, does the angiotensin receptor blocker have any benefit versus the ACE inhibitor? And one trial which compared losartan, an angiotensin receptor blocker, with captopril, an effective angiotensin converting enzyme inhibitor, tested the hypothesis that there is a difference, and it was negative. There was no difference. It was the ELITE 2 trial. There was no difference at all between the outcomes in patients treated with captopril versus those treated with losartan. How about mineralocorticoid receptor antagonists, or anti-aldosterone drugs as they're sometimes called? There are several trials now. The earliest, the RALS trial, included several patients who were receiving beta blockers, but a much larger group of patients receiving ACE inhibitors. These were functional class 3 and 4 patients, and in that population, spironolactone had a markedly and statistically significantly greater impact on outcome, providing more benefits than placebo. Emphasis was a later trial using eplerenone, another MRA, and it included a large number of patients who were in functional class 2. Those patients predominantly were receiving ACE inhibitors or ARBs, and also predominantly were receiving beta blockers, which by that time had become apparently very useful for patients with HFrEF, and I'll talk about that in a few minutes. That study, too, showed a statistically significant benefit of the MRA versus placebo for patients with HFrEF. Now, how about the impact of heart rate? When we discuss beta blockers, we really do have to consider heart rate. What does heart rate have to do with the pathophysiology of heart failure? First of all, increasing heart rate leads to an increased demand for oxygen and for high-energy substrates in the myocardium. And in patients with heart failure where there's already a deficiency of substrate and oxygen, the increase in demand for oxygen leads to a decrease in left ventricular function and an increase in the clinical appearance of heart failure in the short term. In the long term, there is an increase in death, heart failure death and sudden death both. Heart rate at rest is a predictor of cardiovascular death and or heart failure hospitalizations in patients with HFrEF. In the SHIFT study, which involved 6,000 some odd patients with heart failure, all HFrEF, all with heart rate at least 70 beats per minute at entry into the study, the population was divided into quintiles based on heart rate. And it was clear from the outcome that outcomes worsened as heart rate increased and worsened in a stepwise fashion. The lowest heart rate quintile had a highly significantly different outcome, better, than the highest quintile based on heart rate. And for each quintile in between the lowest and the highest, as the heart rate increased, the outcomes worsened. So it's not surprising then that when all the beta blocker studies that were available at the time, together with other heart failure studies that didn't use beta blockers, were put together in a meta-analysis, the lower the heart rate, the greater the reduction in heart rate from baseline to on therapy, the greater the improvement in survival in patients with HFrEF. And in fact, if heart rate increased, as it did with certain drugs, survival worsened. So clearly, heart rate is a major factor in the outcome of patients with HFrEF. And just as clearly, beta blockers, which decrease heart rate, have much of their effect, if not their predominant effect, by reducing heart rate. Now finally, during the studies of a variety of these agents, it became clear that there were racial characteristics, genetic characteristics, that would alter the response of certain groups of patients to certain of the agents that otherwise might be beneficial for patients with HFrEF. One of these groups that's particularly important in the United States is African Americans. African Americans don't respond as well to beta blockers or to RAS blockers as do Caucasian subjects. However, it was observed that using a combination of hydralazine and nitrates in African Americans with HFrEF led to a beneficial response. In fact, there was, in a trial called the AHEF trial, a substantial and significant reduction in mortality in patients with HFrEF who were African American, who were treated with isosorbide nitrate plus hydralazine versus those treated with placebo. In summary, heart failure is a syndrome with complex pathophysiology that involves a neurohormonal response. The response results in a variety of hemodynamic and other manifestations which define the clinical syndrome of heart failure. Activation of the sympathetic nervous system, the renin-angiotensin-aldosterone system, and the natriuretic peptide system contribute to the neurohormonal response. Increased heart rate is a risk factor for cardiovascular death and hospitalization in HFrEF. The differences in response of HFrEF and HFpEF to different groups of medications reflects the heterogeneous nature of heart failure. Thank you.